Okay, it's 12:30. Why don't we go ahead and get started? Welcome everyone to the latest in Worth Publishers TLC Symposium Series. My name is Daniel DeBonis. I'm a Senior Acquisitions Editor with the Psychology list for Worth Publishers. And I'm here to welcome you to our talk today on teaching about psychopathology, implications of DSM-IV, and other recent advances given by our new author, Dr. Matthew Nock of Harvard University. Before we get to the talk, I'd just like to provide you with a few housekeeping notes. As you may have noticed when you joined the webinar, everyone is going to be on mute to keep the background noise during the talk to a minimum so that we can hear Dr. Nock clearly. At the end of the talk, once Dr. Nock is done, we're going to have a Q&A session. And some of you already sent us some questions that you'd like to have addressed about the revision, the DSM-IV. We'll be selecting some of those questions. If you have a question in the course of the talk that you'd like to suggest, you're welcome to also type it into the chat window. If you don't see the chat window on your screen, what you can do is scroll your cursor to the top of your screen, and a green bar should come down as part of the WebEx frame, and chat is one of those options, and you should be able to get that chat box to appear. And if you have any, in addition to questions, if you have any issues with the WebEx as we go along, feel free to notify us in the chat, and we'll assist you. Finally, at the end of during the Q&A session, we'll also be taking some questions directly from attendees. If you have a question that you would like to ask in person, please indicate that by clicking on the raised hand icon. And in the WebEx frame, you can see by the chat box there's this little hand icon. Just click person at the end if there are any questions. Great. Now to introduce our speaker today. Matthew K. Nock is Professor of Psychology at Harvard University, where he is also the Director of the Laboratory for Clinical and Developmental Research. He received his bachelor's degree from Boston University and his PhD in psychology from Yale University. His research is aimed at advancing the understanding of why people behave in ways that are harmful to themselves, with an emphasis on suicide and developing tools for measuring ideation of suicide. This work was recently profiled in an article in the New York Times Magazine titled The Suicide Detective. His research is multidisciplinary in nature and uses a range of methodological approaches to better understand how self-harm behaviors develop, how to predict them, and how to prevent their occurrence. And aspects of this will be covered in today's talk. His work has been recognized through the receipt of 4 early career awards from the American Psychological Association, the Association for Behavioral and Cognitive Therapies, and the American Association of Suicidology. And in 2011, he was named a MacArthur Fellow. He has acted as a scientific advisor to the National Institutes of Health, the World Health Organization's World Mental Health Survey Initiative, which will figure in today's talk, the American Psychological Association, and the American Psychiatric Association DSM-IV Childhood and Adolescent Disorder Work Group, which will figure in today's talk as well. This January, he will join Daniel Schachter, Daniel Gilbert, and Daniel Wegner as the co-author of Psychology, 3rd edition from Worth Publishers. And I'm also pleased to announce that Matt is also the very latest author to be published by Worth, as he authored a short guide for teachers entitled Updates on DSM-IV for Introductory Psychology, which we published in July. We've already distributed this short guide to adopters of the Schachter-Gilbert-Wegner textbooks. If you would like to receive a copy and have not, there are 2 ways to request one. One is to go to our site at worthpublishers.com, and if you search for Matt Nock, you'll find it and can request a copy through the website. Alternatively, you can email today's host, Andrea Messinio, and just let her know that you'd like to receive a copy, and we'll be sure to send one out to you. Finally, if you're using a Worth textbook in your introductory psychology course this semester or next semester, we have some additional information for students that's posted online at www.worthpublishers.com /DSM-5 update. I'll type that URL into the chat window so everybody has it, and you have additional information for your students there. Now, without further ado, I'd like to turn things over to Dr. Nock.
Great. Thanks so much, Dan. Thanks, Andrea. Thanks, Worth, for putting together this webinar, and thanks for inviting me to present. So as advertised, I'm going to be talking today about teaching about psychopathology, and we'll talk about implications of DSM-IV and some other recent advances. So one could think of this talk as sort of a what's new in psychopathology, and what I'd like to do is highlight some new directions in psychopathology and highlight how they might impact and be incorporated into your teaching. And there are four main things I'd like to cover today. First, I'd like to talk about some new information that's now available about mental disorders from several large-scale epidemiological studies. I'd like to spend a good amount of time talking about DSM-V, which I think is something people are probably most aware about and potentially most excited about, and will definitely have an impact on what's covered in intro psych textbooks and abnormal psych textbooks and what's taught in the classroom. I'd also like to, looking forward, say a little bit about the research domain criteria, which many of you may have heard about already, and if not, you will be hearing more about it soon. So I'll talk about the RDoC, as it's called, which is a new way of thinking about mental disorders. And then I'll conclude by saying just a little bit about some new directions in how we are measuring and treating disorders that are using recent advances in psychological science and recent technological advances to change the way this is done. So something also important for our students to know about moving forward. So we'll start with number one and work our way down the list. So historically, information about the prevalence, the course, the correlates, and the treatment of mental disorders has been available from small regional studies, small studies in the northeastern United States or southwestern United States on people with depression or small groups of people with substance use disorders. And such studies provide information of questionable reliability. And recently, there have been a coordinated series of large-scale epidemiological studies done in the U.S. and around the world. And this is all under the auspices of the World Health Organization World Mental Health Survey Initiative, led by Ron Kessler at Harvard Medical School. And this is a series of epidemiological studies done in the U.S. as the National Comorbidity Survey, and there's a little tab here on the left that you can see, and replicated around the world in about 24 countries. And this study is collecting and providing at this website really interesting information about what mental disorders look like in the U.S. and around the world. And so this website here provides sort of a one-stop shopping for any additional information you'd like to incorporate into your lectures or to share with students in sections or however you want to do that. There's really detailed information at this site to allow you to drill down. And I'll talk a little bit about some of the kinds of information you can find there. So the World Mental Health Survey Initiative, to provide a little more information, is being done in over 24 countries in all regions of the world. And in each country, there's a nationally representative sample of about 5,000 or more people who receive household interviews. They're interviewed in their home for about 2 hours. And information that's presented on the website in the form of research articles or tables talk about the prevalence, the course, the correlates, and the treatment of mental disorders. These are the current World Mental Health countries, so data are truly from all over the world, and this provides really nice cross-national and cross-cultural information about mental disorders. For instance, we're learning about what percentage of people have mental disorders. So what is the 12-month prevalence of DSM disorders? This figure here summarizes what's been found so far, and there are several things to note from this figure. One is mental disorders are pretty prevalent around the world. So this is 12-month prevalence. So in the past year, what percentage of people have a mental disorder? And we see the rates vary from about 10 to 20 or so %. So we see rates are high. The U.S. has the highest rates, and before we all start chanting USA, USA, I remind you these are data on mental disorders, so we don't necessarily want to be #1 here, but we are. Interesting, there's great variability cross-nationally, and that's something that I think is interesting for researchers to think about, but for students as well. Why do we see such cross-national variability? And there's a number of potential explanations for discussion. It could be that there are true differences cross-nationally in the presence of mental disorders. There's differences in risk factors and protective factors that lead to these true differences. It's also very, very possible that the differences in stigma and likelihood of reporting mental disorders vary dramatically across these countries, and this can have a huge impact. So it's okay in the U.S. to say that you have depression or anxiety, whereas it may be taboo in other countries. Another part of the explanation may be that disorders manifest differently in different parts of the world. And in this study, although it's cross-national, we're looking here at DSM disorders. So they're Western conceptualizations of mental disorders. And so we see some Western countries on top of the list and some Eastern countries in the bottom. It could be that if we used Eastern conceptualizations of mental disorders, these rates would change a little bit. And there's other potential explanations as well, as you can imagine. But the point I want to make is that these data provide a really nice method of digging down. These are data on any disorder. And although we see variability, I think what's interesting to note is anxiety disorders, although they vary in prevalence, are consistently the most frequently reported in all countries examined. So you see on the bottom of the scale here, rates go up to 20%. Mood disorders occur much less often, only up to 10% of people in these different countries. Disruptive behavior disorders like oppositional defiant disorder, ADHD occur even less frequently, followed by substance use disorders. And here we see the U.S. move out of the top spot. So although there is variability in reporting, the overall rates of disorders, anxiety more than mood, more than disruptive, more than substance use, is very consistent cross-nationally. It's also important to think about severity, and this I think is something especially important to convey to students. These numbers seem really high. So a student might say, so you're telling me a quarter of people within the past year have a mental disorder? That's a really high percentage. It's a true percentage, but it's also important to keep in mind that many of these disorders are not of great severity. And severity here is defined by impairment in functioning, inability to perform one's daily responsibilities, making suicide attempts, and so on. So if we classify cases as severe, we see that if you look at the percentages here, let's take the U.S. as an example, only 25% of cases in the U.S. are severe. So most cases of mental disorders are mild or moderate in severity, and this is true in the U.S. So 25% of people in the U.S. meet criteria for a disorder in a given year. Only 25% of those cases, or about 6%, have a severe disorder. And when we say severe disorder, we do mean severe. People are impaired by mental disorders. They are real disorders. As an example of that, this is among those with a severe disorder, how many days are they out of role, meaning unable to perform their daily responsibilities as a worker, a student, a parent. And we see here the numbers vary from about a month to about 6 months out of role, but these are real impairments in functioning. And so I think an important point to make that when disorders are severe, there is significant impairment in people's daily lives. This survey also provides information on treatment, and here is shown the 12-month treatment by severity of disorder. So first shown here is serious disorders, and we see that in high-income countries, there's greater rates of treatment than in low-income countries, as you might expect. And we see with lessening severity, there is less treatment. An important point to make here is that most disorders, even in wealthy countries where there's severe disorders, about half go untreated. So even severe disorders where people have many days out of role, they're unable to perform the responsibilities, we're not treating them. If you were not depressed yet, I've got one more slide. The proportion of treated cases who get minimally adequate treatment by current standards or guidelines is also pretty low. So for serious disorders, even in high-income countries like the U.S., less than half of those who are treated get adequate treatment, meaning they might have gotten 1 or 2 sessions of psychotherapy or 1 or 2 medication visits. And if we look at all countries, all cases, the data are even more depressing, especially in the U.S., where of those people in the U.S. with a disorder who are receiving treatment, less than 20% are getting treatment that would be considered adequate. So the big picture here is disorders are prevalent. In a smaller percentage of cases, they are severe, but that severity is indicative of impairment, and we really have a long way to go in terms of providing people with effective treatment. So this is just a few examples of how you could dig down into these data and provide more information about mental disorders and their treatment, and I would definitely encourage you to check out the World Mental Health website for more information cross-nationally. And again, if you click on the National Comorbidity Survey tab on the left, you'll get information that's U.S. specific if that's what you're interested in. So I want to shift now from talking about information about current disorders to talking about changes in how we classify disorders and thinking about what's new in DSM-IV. And there's a major shift happening now in how disorders are classified and how they're being studied. But to understand that, I think it's really important to consider how we got to where we are. So I think we need to sort of look backwards and know where we are now and where we're headed. So the DSM is, of course, the Diagnostic and Statistical Manual of Mental Disorders, and this is the manual that we use to classify and define different disorders. It had its roots over 150 years ago when the Census Bureau was instructed to start collecting information about what percentage of citizens in the U.S. Had idiocy or insanity. So the government realized that they didn't have good information on things like disability, like blindness and deafness and insanity, and so the Census Bureau started collecting this information in a really crude way. And this evolved a little bit over time, and then in 1917, we saw the birth of the Statistical Manual for the Use of Institutions for the Insane. And this was, as it sounds, an accounting of what types of patients were in the U.S. psychiatric hospitals. And rather than just saying what number of patients are there, we started grouping them into different categories, and there were seven broad categories that were examined. In World War II, there was a big shift in mental health in the U.S. and around the world, and psychiatrists and psychologists moved from operating almost primarily in psychiatric hospitals to working to a very large extent with service members who were in need of mental health care. And the World Health Organization's International Classification of Diseases, 6th edition, for the first time after World War II, included mental disorders as one of the diseases that they examined. Not to be outdone, the U.S. soon after followed suit and created the first version of the Diagnostic and Statistical Manual of Mental Disorders, which was the U.S.'s first system for formally diagnosing mental disorders post-World War II. The first DSM was brief by today's standards, only 130 pages, had just over 100 disorders, and it was very psychodynamically oriented and included narrative descriptions, sort of short paragraphs describing what people look like who have neurosis reaction, personality disturbance, and so on. So some broad definitions. This book was updated in 1968, and DSM-II came out, and it looked roughly the same. It was still very psychodynamically oriented. There were broad descriptions, not yet symptom lists like we have today, and there was still a focus on things like neurosis and psychosis. It was around the same length as DSM-I. DSM-III saw a huge shift, and this was due to threats to the credibility of the entire mental health system. And what was happening, in short, was clinicians were not able to reliably diagnose patients. So clinician A and clinician B might see the same patient, and one clinician would say this person clearly has neurosis, the next person would say they have psychosis, the third clinician would say no, it's a personality disturbance. So people were using these definitions, using these categories differently. And important to note, DSM-I, DSM-II, all we really had at the time was clinical observation and psychodynamic conceptualizations. And so clinicians used what they had. They had their observations of what patients were reporting, and they used that to classify people. In 1980, with the birth of DSM-III, there was an attempt to make psychiatric diagnosing much more credible and much more reliable. And so Robert Spitzer, who headed up DSM-III, thought it would be a really good idea for us to have, as in other areas of medicine, lists of symptoms so we could more reliably diagnose people with depression and schizophrenia and panic and so on. And he borrowed these lists of symptoms that were already created from the research diagnostic criteria, which were lists of symptoms that researchers were using at the time so that they were sure they were reliably characterizing patients as having depression or schizophrenia and so on. And so he took the research diagnostic criteria and used this for the foundation of DSM-III, and this is when we saw the list of symptoms that people describe as sort of Chinese menu lists, where to meet criteria for a disorder, you have to have 2 from this list and 3 out of 5 from that list and so on. This led the manual to be much, much longer. It was almost 500 pages, included over 250 disorders, and did increase the reliability of diagnoses. DSM-IV had a continued emphasis on reliability, and it was updated with new research that happened over time. A steering committee was formed for DSM-IV that had 23 psychiatrists, 4 psychologists, so we see psychologists starting to play a role. And this book was much longer than the earlier one, had a few more disorders. And we can see how this book, the DSM, expanded over time, with 1 and 2 on the bottom being little pamphlets compared to DSM-3 and 3R and 4 and 4 text revision on top. So the book is getting larger and larger. As there was a big shift with DSM-3, there's the beginnings of another big shift with DSM-5. And so in many ways, DSM-5 is similar to DSM-4. There's more that's kept than changed. On the other hand, we're starting to see, I think, foreshadowing of what's going to come in the future. And from DSM-2 to 3, we saw a big shift with a focus on reliability. With DSM-5, we see a shift to the focus on the validity of our diagnoses. And so what we're beginning to understand is that these disorders that we have in DSM-4 and 5 are not mapping onto findings from genetics and neurobiology and other studies in psychological science. And so there's a perceived need to change the way that we're organizing and conceptualizing psychological disorders that better maps onto what we're seeing in our studies that might tell us about underlying mechanisms leading to disorders. And I'll say more about that when we talk about the research domain criteria project. So DSM-5 took over a decade to plan and to pull together. There was a series of work group meetings where included were about 100 psychiatrists and nearly 50 psychologists. So we're seeing psychologists play a much larger role in DSM. There were a series of meetings in DC. There were 2 online drafts for public comment, so very different with DSM-5. Now with the internet, all of the information that was considered to be included in DSM-5, or a lot of it, was posted online and people could comment on it publicly. And the final version of DSM-5 was released just this past May. So I want to talk about what some of the major changes are, and if you're interested, DSM-5.org has all of the changes outlined really nicely. It's a pretty user-friendly website, and if you're interested, I encourage you to check it out. So DSM-5 has 3 main sections. The first section, aptly called Section 1, is simply a description of the DSM process, the work groups, and the manual itself. Section 2 is the real meat of the manual, and this is where we see listed the clinical disorders. There's 20 different chapters of disorders and over 200 disorders included. And Section 3 is I think, really interesting. Listed there are research initiatives, alternative ways of measuring personality disorders. There was plans for a big change in personality disorders for DSM-5. That didn't quite happen, but alternative models for the future are listed in Section 3. Also are some new conditions for further study, some cross-cutting dimensional measures. So DSM is now providing in the book and on the website dimensional measures for people to use, which could be interesting to show students as well. V-codes are still there, and cultural formulation is there, but changed. There are no longer culture-bound syndromes as there were in the past. The thinking is that now mental disorders are mental disorders, just as, say, cancer is cancer everywhere around the world, but the disorders may manifest differently. Distress may manifest differently in different parts of the world. And so they're no longer different disorders, but just different manifestations is the thinking of DSM-5. And now included is a cultural formulation interview that clinicians are encouraged to use to assess how people think about the conditions they're experiencing. So a really interesting change there, and one that is also in line with the research domain criteria I'll discuss later. So what are the big changes? We all know and love the multi-axial system, the 5-axis system, where acute clinical disorders are on axis 1, personality disorders are on axis 2, and so on. That is now gone. There is no longer a multi-axial system. That's the first really big change. Another change is how the disorders are organized in the manual, and we have some new categories. So this is a list of the 20 chapters in Section 2, again, the real meat of the book. And there's a reorganization of these chapters, and this organization, the sequence now, is based on advances in our understanding of underlying vulnerability for disorder, as well as in the similarity of symptoms across different disorders. And I'll talk through some examples of that to illustrate what we mean. So we start with neurodevelopmental disorders, things like autism and ADHD, which begin early in life. And those share some similarity to schizophrenia spectrum disorders and psychotic disorders in that they are disorders of thought and communication, and so these are adjacent to each other. Recent studies have shown some shared genetic vulnerability for psychotic disorders, bipolar disorder, and depressive disorders, and so those are grouped adjacent to each other. And because of presentation, we see bipolar disorder is now pulled out from mood disorders. It's its own chapter, its own class of disorders, And the reason it's organized the way it is, bipolar disorder, people with bipolar disorder share some symptoms with people with psychotic disorders and their psychotic thinking and their experience of psychotic symptoms, but they also share overlap with depressive disorders in that they have major depressive episodes. And so bipolar is now thought to be a separate entity that sits between schizophrenia and depression. Mood and anxiety disorders, of course, have a lot of overlap, and those are adjacent to each other. The anxiety disorders are broken up a little bit. Obsessive compulsive disorder, PTSD, are now separate types of disorders. And the idea being that as we have learned about etiology of these disorders, we've learned that they're different. There's a different neural circuitry, we think, for OCD than there is for things like generalized anxiety disorder and phobias. PTSD and other trauma-related disorders occur in response to a trauma or stressor, different than other types of anxiety disorders. So those are now broken out to be separate types of disorders. We then see disorders of eating and sleeping and sex and gender. Disruptive disorders are grouped together. So we have ODD, oppositional defiant disorder, grouped with conduct, grouped with intermittent explosive disorder. So it doesn't matter if they're disorders of childhood or adulthood, they're all in this chapter. Antisocial personality disorder, impulse control disorders like kleptomania. These are all disorders of disruption and impulse control, and so they're grouped together. They're thought to have a similar etiology. Disorders of addiction are together, whether they're substance-related or gambling-related. Axis 2 is gone. With the multi-axial system, axis 2 has disappeared, so personality disorders are a separate chapter on the same axis, so to speak, in the same grouping as all other disorders. And I'll talk more about that in a moment. So you can see the types of changes that are happening here. So again, a lot of the disorders are the same. Bipolar is still there. Major depression is still there. OCD is still there. But we're seeing some reorganization of where they sit and how they're thought about. There's some other big changes that may affect teaching, whether you're teaching intro or abnormal or related classes. And I'll go through just some of the key ones. There's a removal of the bereavement exclusion for major depression. It used to be in DSM-IV, and in a lot of textbooks, there's a little statement saying depression is different than sadness after a loss. And in DSM-IV, you had 2 months of grieving time, so to speak, before you were considered to have major depression. In DSM-V, there's no such exclusion. And the rationale here is death is a stressor just like other losses or negative life events are stressors. And if we're trying to classify disorders as true illnesses, or understand them as true illnesses, the type of stressor should be irrelevant. There's now an autism spectrum disorder, which puts 4 different disorders from DSM-IV under one umbrella. So in DSM-IV, we had autism, Asperger's syndrome, child disintegrative disorder, pervasive developmental disorder, not otherwise specified. In DSM-V, they're all under one umbrella. And so there's no more Asperger's syndrome. It's now, they're all just autism spectrum disorder. And the rationale here is that this leads to a more accurate and consistent diagnosis, that there aren't reliable or valid distinctions in what we saw in DSM-IV. And this has been a pretty controversial change, in part because it's led some people who used to meet criteria for an autism spectrum disorder in DSM-IV to no longer meet criteria because there's been some changing of the symptoms, and that's led a lot of people to be unhappy. Another controversial change is the addition of disruptive mood dysregulation disorder, which is a disorder characterized by persistent irritability and behavioral outbursts in kids. It was added because there was concern about an overdiagnosis of pediatric bipolar disorder. The controversy here is there's still a concern that we are pathologizing developmentally normal child behavior. We're pathologizing temper tantrums, and we already have oppositional defiant disorder, which itself is controversial, and now we're adding another disorder of childhood, and many people don't like this change. We also see personality disorders moved onto the same footing as other clinical disorders onto Axis 1, and the reason for this change is that we used to think about personality disorders, and they've been written in textbooks, as lifelong persistent disorders. Studies like the NIMH's Collaborative Longitudinal Personality Disorder Study have shown that they're not lifelong. For instance, one recent study followed people who met criteria, rigorous criteria, for borderline personality disorder for 10 years, and about 85% of them remitted and only 12% relapse. So after about between 6 and 10 years, many people who had a personality disorder no longer met criteria. So they may still struggle with, in the case of BPD, affective lability and trouble with relationships, but they no longer met personality disorder criteria. And so the way we're thinking about personality disorders is changing to be more acute disorders and not lifelong. There is a debate about how we should conceptualize personality disorders. Should we use categories versus dimensions? And there's a lot of discussion about this. Ultimately, in DSM-V, the manual retained the 10 personality disorders from DSM-IV, but add a dimensional approach that's in the book, and you can get the access to the dimensional measures online. Another big change is the addition of a suicide behavior disorder and non-suicidal self-injury disorder to DSM. And these are added to Section 3 as conditions in need of further study, but it's significant that these behaviors are for the first time added as actual disorders. They're often, well, self-injury is often not covered in intro or abnormal, and suicide is often covered along with depression. And the thinking is that these are separate, that they're not necessarily linked to depression, and so they should be studied in their own right. So why should that be? Why should we focus on self-harm? These are really prevalent, really concerning behavior problems. So in the case of suicide, about 1 million people kill themselves each year around the world, which means one person takes their life somewhere around the world every 40 seconds. There are about 35,000 such deaths in the U.S. each year, meaning there are more than 4 times as many suicides as HIV/AIDS-related deaths in the U.S. each year, more than twice as many suicides as homicides each year in the U.S. And suicides outnumber homicides worldwide. More people die by suicide than all wars, all genocide, all interpersonal violence combined, which, if you think about it, means we're each more likely to die by our own hand than we are by someone else's. Suicide is the 10th leading cause of all death in the U.S., 3rd among adolescents and young adults, 2nd among college students. So this is something that's really, I think, relevant to college students. And this is something that really falls in the hands of psychologists. So higher up leading causes of death, things like cancer and heart disease, are studied by oncologists and cardiologists. Suicide is really the mind turning on itself, or the mind turning on the body. And so this is something that's squarely in the domain of psychologists. And so I think, although I'm biased because this is my area of research, we should be focusing on this more and more. And it's a problem that's ours to try and solve. So how big of a problem is it around the world? Using data from mentioned earlier in this talk from the World Health Organization's World Mental Health Survey Initiative, looking across a few dozen countries, we see that about 9% of people say that they have seriously considered killing themselves at some point in their life. 3% have made a plan to kill themselves. 3% have actually tried to kill themselves. You'll see here, as we saw before, lots of cross-national variability, with the U.S. being high here as well. So about 15% of people in the U.S. say they've seriously considered killing themselves. 5% have attempted, 5% have planned. A lot of that happens during adolescence. So when people are coming into college, many will have already experienced suicide ideation. This figure shows for 17 different countries we examined the cumulative age of onset distributions for suicide ideation, so increasing risk of first onset of ideation. We see virtually no suicidal ideation or thinking in childhood, and in every country we examine, we see a skyrocketing in thoughts about suicide during adolescence and young adulthood. So although there are differences in the rates of suicidal thoughts and behaviors cross-nationally, once people say they're there, they look very similar in every country we examine. And in thinking about should we lump suicide in with depression, one thing we did with these data was look to see which disorders, and we looked at 16 different disorders, which disorders predict suicide ideation. And this is just a summary from 4 disorders. We see most disorders are associated with an increase in the odds of, these are odds ratios, in the odds of suicide ideation. Depression has the strongest link, as you would expect. So if you have major depression, you have a doubling in your odds of thinking about suicide. We then said, well, what predicts among those who are thinking about it, who acts on their suicidal thoughts? And there, depression is unrelated. An odds ratio of 1 means it does nothing. What does predict acting on your suicidal thoughts are disorders characterized by anxiety, agitation, poor behavioral control, highlighting the fact that suicide is not just a problem of depression, but depression interacting with other types of disorders. Non-suicidal self-injury, separate from suicide, refers to direct, deliberate destruction of one's body tissue in the absence of any intent to die. Often takes the form of cutting or burning or scratching or on the right here, inserting objects under your skin. An increasing number of kids are doing this. And we see the rates of this behavior also fairly high, especially among adolescents, with about 15 to 20% of high school and college kids saying that they have engaged in self-injury. So again, something that folks in your classes may be either struggling with or exposed to in some way. And we're seeing an increase in research on self-injury. This is just a quick figure showing the number of published articles focused on self-harm, self-injury, self-mutilation. It's gone by many different names. And we see in the past 10 years a huge increase in studies in this area, and so what we know about this area. So I think this will be a larger clinical focus and a larger, hopefully, educational focus moving forward. So I want to switch here from talking about DSM to talking about the research domain criteria. And this is really sort of looking forward to how disorders may be classified moving forward. The Research Domain Criteria Initiative really has grown out of a dissatisfaction with the DSM approach. And as I mentioned earlier, the fact that a lot of what we're learning from genetics and neurobiology and psychology is not mapping cleanly onto one disorder. We see a lot of comorbidity, and we don't see results from studies mapping onto individual disorders. And so the Research Domain Criteria Project is, according to NIMH, a new method of classifying psychopathology based on dimensions of observable behavior and neurobiological measures. And you remember earlier the research diagnostic criteria were used in DSM-IV to sort of change the way that we define disorders. The thinking here is the research domain criteria are going to be used to change the way that we think about disorders moving forward. And the rationale here is that DSM has historically been based on clinical observation. So clinicians see someone coming into their office, the patient describes what they experience, the clinician makes a diagnosis. This is great for reliability, terrible for validity, for understanding what mechanisms lead to the symptom presentation. As an example, if patients come in complaining of chest pain, clinicians can very reliably diagnose that as chest pain. The chest pain may be caused by a number of different problems. It could be asthma, it could be gastroesophageal reflux disease, it could be a heart attack. Just going on the observed symptom isn't going to tell us about the underlying mechanism. And the same is true with the thinking in the research domain criteria. So the RDoC approach is dimensional in that it spans from normal to abnormal behavior, and abnormal behavior is thought to be sort of deviations from normal psychological processes. The RDoC approach is agnostic about current categories. It's not attempting to break down current disorders, but instead to focus on how disorders are constructed from the bottom up, so sort of throwing out the DSM in many ways. And it focuses on understanding disorders from looking across multiple levels of analysis. What's nice about this is it's a very psychological approach, and again, conceptualizes disorders as arising from deficits or dysfunctions in normal psychological processes. So this is the working matrix of research domains from the NIMH website. The domains are listed on the left, and researchers are working to fill in information about genes and molecules and cells and circuits and so on related to these different processes. And so these are the processes that NIMH thinks we should focus on. And you'll notice they focus on negative and positive valence, so emotion, motivation, learning, perception, memory, language, social processes, and disruptions in these processes are believed to work together to lead to psychological disorder, and so NIMH wants us to study these basic processes and try and understand how they might lead to different disorders. If you look at these constructs that are underlined in red, they look to me and to many people like the chapters in an intro psych textbook. And so what I think is really nice about this approach is it takes mental disorders and relates it to what we're teaching students about emotion and motivation, about learning, perception, memory, and so on. And so it really brings disorders more in line with the rest of psychology. So I think this is a really valuable approach. And if you're interested in learning more about this, here's the NIMH's link to their research domain criteria project. And you can look in the cells of this matrix and see in real time as these things are being updated. And so this hasn't had a huge impact on DSM-V because this work is ongoing, but I think it will have a big impact moving forward. And you'll notice we've moved away from Roman numerals in DSM-V. And the reason is, as research is happening, there's going to be an effort to make updates more frequently, so we don't have to wait another 20 years till DSM-VI to make changes. So we're going to see a DSM 5.1, 5.2, 5.3 as changes are being made. And so hopefully these will be making their way, the big changes will be making their way into textbooks and into classrooms. I want to end with the few minutes that I have left talking about how assessment is changing. And I think there's some big changes happening here as well that I'll try and convey really quickly. And I'll do that by giving my own very brief and admittedly very selective history of psychology on one slide in about 30 seconds. So what I'd like to highlight are, again, these are my own thoughts here, how we have measured and tried to change clinical behaviors over time, and how basic research on behavioral and psychological processes has impacted that. So in the beginning, the Greek sophists used talking to people who were mentally ill, who had mental disorders, who had melancholia, talking them out of their sad states for a fee. And many cognitive therapists, such as Beck, refers back to Epictetus and others as the original cognitive therapist. It is not thinking that nothing is good or bad. It is thinking that makes it so. And this idea has been around for thousands of years. A lot of textbooks talk about the work of Franz Anton Mesmer and his use of animal magnetism or mesmerism as being one of the earliest forms of psychotherapy. And we've learned through a brilliant series of randomized clinical trials by Benjamin Franklin that a lot of this, or all of this effect, was due to the power of suggestion and possibly hypnosis. Around that time, we had the birth of psychology with the work of Wilhelm Wundt and William James. In terms of therapy, Wundt and James didn't have much of an impact at the time. So Freud's work grew out of the use of hypnosis, which led to free association. So we still have talk therapy here. And there's a little bit of a barrier between what's being done in psychology and what's being done out in practice in terms of talk therapy without a lot of penetration until behavior therapy. We saw students of Skinner's starting to apply results from studies in the lab on classical conditioning and operant conditioning to changes in education and treatment. With the cognitive revolution, we saw a little bit of a breakthrough in how we think about and assess disorders, but we're still using self-report measures of, say, dysfunctional thinking. So the methods of psychological science didn't break through as strongly. And over the past several decades, there's been just a huge amount of work done that's developed new ways of thinking about and measuring memory and learning and attention and brain structure and function and real-time assessment of what's happening. And that work hasn't really broken through until now. And now it's starting to, and we're starting to see clinical assessments and clinical interventions that draw directly from work from basic psychological science. And I'll give just one example and then conclude and have some time for discussion. One area this has happened has been in the study of self-injurious thoughts and behaviors. And since the beginning of time, up until now, what we've done to assess whether someone's at risk for suicide is ask them, do you want to hurt yourself? Do you want to kill yourself? And this is a terrible way to assess whether someone's at risk for hurting themselves because people have an obvious motivation to deny or conceal thoughts of suicide or suicide intent for fear of being intervened upon and being hospitalized. And there's evidence that people aren't reporting honestly. For instance, one of the highest risk periods for suicide death is the week after people are discharged from a psychiatric hospital. So presumably they're telling clinicians they're totally fine, they're not suicidal anymore, but then when they leave, they unfortunately kill themselves. Other data show that 78% of people who die by suicide in the hospital explicitly denied thoughts of suicide in their last assessment before dying. So we know that we need new methods of measuring risk for suicidal or self-injurious thoughts and behaviors that don't rely on explicit report, which has been used throughout time. So in other words, we have a person in front of us saying, I don't want to hurt myself. What we really want to be able to measure is how are they thinking about self-injury or suicide? What are their unspoken thoughts or their implicit cognitions? And implicit cognitions are those that aren't reliant on conscious introspection or explicit self-reporting. And over the past few decades, social and cognitive psychologists have developed ways of measuring implicit cognition using behavior, using tests of memory or reaction time. And one increasingly popular approach is the Implicit Association Test, or IAT, developed by Tony Greenwald and colleagues. And this is a brief reaction time test, about a 5-minute, usually computer-based test, that uses the speed with which you classify different stimuli on a screen to measure the mental associations you hold between different concepts and attributes. And it's been used primarily to study things like how do you think about white people versus black people, old people versus young people, men versus women, Democrats versus Republicans. Some nice features of this test: it's been shown to be reliable and resistant to attempts to fake good. It's been shown to be sensitive to change in treatment, and predictive of future behavior, such as how you vote or how closely you stand next to someone next to the elevator. What we wondered is, can we break that barrier down and use this advance in psychological science to change the way that we do clinical assessment? And so we developed an IAT for self-injurious thoughts. And what this looks like is, if you haven't seen it, this is your computer screen, and you see the concepts of cutting on the left and no cutting on the right. And you see me on the left, not me on the right. And your job is, you'll see stimuli appear on the screen. You have your fingers on a keyboard, your left finger's on the E key, your right finger's on the I key. So left finger's on the left, right finger's on the right. And you see stimuli and you classify them. This is a picture of cut skin, so you push your left button, because it's a me word. Uncut skin, right button, and so on. And what we think is, if you are somebody who is self-injurious, you will respond quickly when cutting and me are paired to the same key, because you associate those as being like each other. You do that for 40 trials, then we flip it, and now cutting is paired with not me, and you do the same task for 40 trials. And what we think is, people who are self-injurious are going to be faster responding when cutting is paired with me compared to not me. And so what we do is generate for each person what's called a D-score. We simply take your average response latency for one pairing, subtract it from the other, divide by your standard deviation of response latencies for all trials to give you a standardized score. And so what we have is a faster score, a positive score, means that you responded more quickly when cutting and me are paired. A negative score means the opposite. So we would expect cutters to respond more quickly when cutting and me are paired, so to have positive scores. And so we did a study where we brought in adolescent self-injurers and non-injurers, gave them this test, and saw huge differences between groups, with those engaging in non-suicidal self-injury in red having a positive score. They responded faster when cutting and me are paired. Those with no such history, a negative score. They responded faster when cutting and not me are paired. This is nice. This is an objective way of measuring how a person thinks about self-injury without relying on their self-report. I can tell by your silence you are not impressed, neither were the reviewers. So we did a follow-up study where we said, can this test help us distinguish between non-suicidal people, suicide ideators, or suicide attempters? And we saw even bigger differences with non-suicidal kids having a negative score, those with suicidal thoughts a slight positive score, and those with suicide attempts a strong positive score. We follow this up with a Suicide-IAT or death IAT. So instead of cutting, which represents self-injury but not suicide in particular, so we changed cutting, no cutting to death and life, and we administered this version of the IAT in a psychiatric hospital, in the emergency department. And what we found was that suicide attempters, people who came in because they made a suicide attempt, had significantly higher scores on this test than people who came in for psychiatric distress but didn't make a suicide attempt. And those with a positive D-score, who we say have an identification with death, 30% of them made a suicide attempt over the next 6 months, compared to 10% of people with a negative D-score. So this test predicted who made a suicide attempt in the next 6 months. Most excitingly to us, scores on this IAT added incrementally to the prediction of suicide attempt above and beyond chart diagnosis, clinician prediction. We asked everybody's clinician, what's the likelihood this person's going to make a suicide attempt? Clinicians, unfortunately, are no better than chance at making those predictions. Better than patients' own predictions, and better than scores on the scale for suicide ideation. So this behavioral test improved prediction. If you are interested in taking a look at this test, or if your students are interested, or other tests, I would encourage you to check out this website we created called Project Implicit Mental Health. And we created it to educate people about implicit cognition, and also as a way to collect data from the public. Here's the website, and this is a snapshot of the website, and you can see the self-harm IATs you can get to on a button on the bottom. But there are also IATs related to eating disorders, anxiety, alcohol, depression, treatment, self-esteem, mental illness. Do you tend to think people with mental illness are dangerous? What are your implicit cognitions? Students can take these tests, you can take these tests, and get immediate feedback if you want it about your implicit cognitions, with all sorts of disclaimers and warnings and appropriate referrals to those who may be at risk. But this is open to the public. Anyone with a computer can go and use it. So a nice demonstration website for class if you are so inclined. So overall, what I hope to convey is that there's new information available about the epidemiology of mental disorders, and that information can be gotten from the website I showed earlier. DSM-IV is here and changing the way we classify disorders. I'd encourage you to check out the DSM-IV website for more information and forms that can be used in class and so on. the research domain criteria is coming, and you may or may not want to incorporate it into your current work and teaching, but it is definitely on the horizon, and I think is going to play an increasing role in how we think about disorders. So I think it's something that's good for students, and especially graduate students, to know about. And the way that we're doing assessment and treatment are changing. I showed only one way, but there's all sorts of changes happening in how we provide treatment, with online and real-time technologies really changing the face of psychological interventions. And I think it's helpful to know about that as well. Thank you very much for your time. I hope some of this was helpful, and I look forward to any questions and discussion.
Thank you, Dr. Nock. We are now going to answer some of the questions that came in during the presentation, as well as any questions that you send us right now. Just send those questions in the chat box. If you do not see a chat box, if you hover over the top of your screen, it should bring up a menu bar that has a chat option, and you can bring that down and ask your question. Okay, so the first question that I have that came in during this presentation is, how will behavioral process addictions, aside from gambling disorder, be coded via DSM-IV, since there is no other or unknown section in this area?
How will behavioral addictions other than alcohol, substance, gambling be coded? Yes. I don't know offhand. That information is certainly in DSM-IV. It may be impulse control disorders like kleptomania. I don't know if that's the focus of the question, but it could be included there. But DSM-IV has, if one looks through it, really specific information about how to code different disorders and what specifiers to use and so on. And DSM-IV has a lot of information. I'm sorry, DSM-5.org has a lot of information regarding how to use codes moving forward. For insurance purposes and so on. So there's lots of rich information on their website to address questions just like this. So it's a dense website, but there's a lot of user-friendly information there.
Okay, I had some clarification from the attendee that asked that question. He said he was referring specifically to behaviors such as sexual addictions, pornography, and shopping.
I think my answer would be the same. I think those would be covered in the impulse control disorders section and not in the addictions. But I'm sure there's, I haven't read the fine detail on that issue in DSM-IV, and I'm sure it's in there.
Okay, thank you. The next question I have is, are you willing to comment on the controversy around the new DSM and the movement by some psychologists to completely abandon the manual and stop teaching it?
Is this being recorded, Andrea?
Yes.
I'm kidding. Will I comment on it? Sure. I didn't know that people were completely abandoning the manual. You know, a lot of us have had mixed feelings about the manual over time. In terms of psychologists, I really like the direction of the research domain criteria, which has not been, NIMH has not been too vocally critical of DSM-IV, but it has said, you know, biology is not in the DSM-IV. Biology is not the Bible. It's more of a dictionary. I'm sorry, DSM is more of a dictionary than a Bible. And so NIMH is moving us in a direction that is more genetic and neurobiology focused, but I think, as I tried to convey, more psychologically focused. So I think it's a direction that's in line with how psychologists are trained and how psychology students are trained. And so I really like that direction. I think it's one that we should, for my own 2 cents, embrace. And I think this is the way the field is going. So, you know, NIMH has said our intention is not to replace DSM-IV, but NIMH is funding research that no longer categorizes research subjects by DSM-IV diagnosis, but instead by research domains. And so as NIMH funds research focused on these largely psychological domains, this is going to shape the way that we think about mental disorders. And so as the funding goes, the research will go, the thinking and the education will go. So I could see abandoning DSM-IV. I could see liking the direction of NIMH, although DSM-IV is the current reality. So I think it's something that students do need to know exists. They need to know about it if they want to navigate the field of psychology and psychiatry. So I wouldn't advocate completely abandoning it, but I could see teaching it not as Bible, but as dictionary, as Tom Insel has said, the head of NIMH.
Okay, thank you. What are some suggested ways of teaching DSM-V to undergraduates and comparing and contrasting it to the DSM-IV?
Great question. As I presented here, I think it's important to not get into the details of what has changed from 4 to 5 for undergraduates, because they, coming in, may not even know what DSM is or may not have a good familiarity. And moving forward, they only have DSM-V to worry about now. So they may not care or be too influenced by what changed. I think it's important, though, to pull way back and focus on the historical context. Why do we have DSM? How did it begin? How has it changed over time? I think the story of shift to focus on reliability, shift to focus on validity can be really useful for students in thinking about what we know and what we don't know about disorders and where the field is headed. So my own 2 cents is I think it's helpful not to zoom in on the micro level details of what's changed from 4 to 5, but to pull way back and think about where the field has come from and where we're headed. And so how students should be thinking about what are mental disorders and how do they link up with what we are learning from research and clinical work.
Great, thank you. Next question is about the IAT. Are IAT results influenced by a person's self-awareness or levels of denial?
Well, I think it's important to keep in mind what the IAT measures. It measures your automatic association, so it's hard to control your IAT score, but it doesn't necessarily measure, unconscious associations. So on a race IAT, if you're doing an IAT on are white people versus black people good versus bad, you may not like black people, and you may know you don't like them, and that will come out in your IAT. You may not, admit to yourself or admit to others that you don't like them, and that may come out in your IAT. So it doesn't necessarily measure complete lack of awareness, and it isn't easy to fake. So if you are aware of what the test is measuring and you're aware of your bias, you can shift performance on the test by trying to speed up on one block and slow down on the other. It's hard to do, and in calculating a D-score, we throw out trials that are too fast or too slow to try and avoid that kind of thing. So yes, there certainly are things that can be done to push around IAT scores, but it can be a hard thing to do.
Thank you. Next question is, are there any efforts underway to study the use of SI-IAT with the various types of suicide, for example, altruistic, anomic, and across cultures?
We've looked at it's a great question. We've looked at so the self-injury IAT seems to distinguish between suicide groups. The suicide IAT distinguishes attempters from non-attempters. It doesn't distinguish self-injurers from non-suicidal people in general, which we would expect. So the suicide IAT is a little bit more specific. We haven't yet looked at relationship between the self-injury IAT or suicide IAT and different types of suicidal behavior. One thing we're hoping to do with Project Implicit Mental Health is to see as a first step, before what this person suggested, which is a great direction, but before that, how does performance on the IAT differ for someone who recently made a suicide attempt versus made a suicide attempt 20 years ago? And what we see is, from looking at the data on Project Implicit Mental Health, is that these implicit associations do change over time. So they're stronger for recent attempts than for distant attempts. We can see, do they differ based on type of attempt? And suicide researchers distinguish between actual suicide attempts, aborted attempts, where a person started to do something, they started to load a gun, but then they stopped themselves, and interrupted attempts, you started to do something and then someone else stopped you, versus just planning. So we can see, are implicit associations with death stronger among those who actually carry out an attempt? As a next step, then we can look at types of attempt to see, as this person suggests, or types of people who attempt, to see how they map on to implicit association. So I think we're right now at the tip of the iceberg of what we can do. We've in some preliminary studies shown that this test can predict. Those effects have been replicated, and now we're trying to dig down and get a sense of what exactly it is that we're measuring and what it maps onto. So this is a direction that's very exciting for us.
Thank you. It is now 1:30 Eastern Time, so this was the time we planned to end the presentation. Matt Nock has been so kind as to offer to continue answering questions, but if you do need to sign off, I wanted to let you know that we will be sending out a recording as well as the PowerPoints, and you can email me back if you want to get a copy of the DSM-IV guide that Dan DeBonis referenced earlier on the call. All right, so for those that have to leave, thank you so much for coming, and have a great rest of your day.
Andrew, don't send this recording to DSM-IV because I was a little critical.
Okay. Okay, so the next question I have is, do you foresee any new textbooks coming out that would take more of a dimensional approach to psychopathology rather than DSM's categorical conceptualization?
Yes, I definitely do. I think that, and any textbook that I'm a part of is going to have that, I would hope would have that focus, and I think we're going to have, we'll see that focus moving forward. I do think it is the way the field is going, and it's, again, important for students to know about this. And so I think it's going to be interesting to see over time how books adapt as DSM-5 and 5.1 and 5.2 come out, and the RDoc picks up steam, how that gets incorporated. Do we say, here are the DSM-5 disorders, but don't memorize them too much because they may be shifting over? You know, how do we convey this to students? And I think it's going to be a tricky thing to try and convey. But I do think it's important to you know, modify textbooks and modify what we're presenting as information is changing. I think it's an exciting time. In other areas, you know, textbooks flip around more quickly as new information is learned. The field changes how it thinks about things. The shifting has been slower in our understanding of mental disorders, but I think it's really heating up. And so it's going to be interesting to see how we as a field adjust. And so I think you'll see more heterogeneity in what's presented in different textbooks. That is how quickly books are adapting to this change.
Okay, great. Thanks, Dr. Nock. What were the major reasons why professionals needed to update DSM-IV?
I think it was just as you mean from 3 to 4, as information was learned about disorders, there were changes in how people were thinking about them and what criteria were being used. I don't know, you know, I came into the field with DSM-IV, so I didn't use DSM-III too much, but I did see some overlap with, or some differences, and it was, from what I know, you know, tweaking of criteria and updating, not so much of a change in thinking. There was still a focus, as I said in the presentation, on reliability, and it was more making modifications based on new research. You know, over 15, 20 years, we learn things about disorders, and, you know, that has to get updated every you know, decade and a half or so. But I think of the change from 1 to 2 as being not so big. 3 was a big shift. 3 to 4, not so big. 5 is a little bit of a shift, not so much in the symptom list, but more in how we're starting to think about mental disorders. And so I think with the 5.XX, and then with 6, we'll see another, I would think, this is just me reading the crystal ball, another big shift.
Okay, thank you. The next question, I've had a couple of people ask this. In DSM-IV, there were defense mechanisms and defensive functioning. What happened to all the thinking and research around these concepts?
What happened to the defense mechanisms?
Yes.
I don't know. You know, they're not, I haven't seen them in DSM-V. I don't think they're in there. And this outside of my area, so I don't know what the decisions were or why they were made.
Okay, thanks.
Sorry.
No problem.
I don't want
to
speak on something I don't know well.
Okay. Is DSM-V applicable to all cultures?
DSM-V believes DSM-V is applicable to all cultures. And the cultural formulation section, as I mentioned briefly, talks about how distress may manifest differently in different cultures. And DSM-V is designed in a way to map onto ICD, which is used across different cultures, the International Classification of Diseases. And DSM-V got rid of the global assessment of functioning on Axis 5 and is now using the World Health Organization Disability Assessment scale or schedule, which is also meant to bring DSM in line with what's done across other countries and cultures. So I think so. I think it's trying to be very, very responsive to and consistent with what's happening in other parts of the world. That being said, it's still a Western conceptualization of mental disorders, and so that, you know, we are going to see differences around the world. And so I think it's changing, but it's not yet perfect.
Okay, thank you. This one also I just received for the second time. In what ways do religious beliefs, particularly as related to glorification of death, affect results on the SI-IAT?
It's a great question. We don't know. It's something we've thought a little bit about. Not so much in religious beliefs. It's a great thing we hadn't looked at or haven't thought to look at. We've thought about how IAT scores may change as people get older and closer to death, how they might change in soldiers who maybe are thinking more about death. And what we think is, as people identify more with death, given their age or their experience of combat or perhaps their religious beliefs, differences between those who are suicidal versus not may diminish. And so we may see weaker effects in the elderly, in military samples, or perhaps in some religious samples. It's a great question, and we don't yet have the data to answer it.
Thank you. That was really helpful. We've received a few questions regarding the multi-axial system and why they did away with it, and how diagnoses would now be written with that model being gone.
Sure. So, and this is described, I think, fairly well in the early part of the in section 1 of DSM-IV, so people have it. It is described pretty quickly, so it's a pretty short read. If you have it handy, I'd recommend checking it out. What DSM-V says is, you know, it looks like a lot has changed, but don't worry. This is my paraphrasing. Not that much has changed. Axis 2 is gone because of what we now know about personality disorders. So you still code personality disorders. Everything is now just on the same axis, so to speak. They're clinical disorders. If people have medical conditions, former axis 3, that you think are relevant to their mental disorder, you should list that too, and there are ICD codes that can be used for that. Axis 4, psychosocial functioning, is now gone, but there are V codes that address that, so you should still use those V codes. And Axis 5, the global assessment of functioning, is gone, but we still have the HUDAS scale, and you should include that score. So they're no longer written as Axis 1, Axis 2, Axis 3, Axis 4, Axis 5, but you do list the disorders, and you note which is primary. You can list other medical conditions. You can list the V codes. So the axis, you know, numerals are gone, but you should still report the information.
Great, thanks. Next question, have there been any tablet-based implicit measures, and have eye movement assessments through tablet-based protocols been developed for implicit assessments?
Not by us. I don't know if, I haven't seen this in the field, but that doesn't mean it hasn't been done. It could be work that's going on now. We're in the process of putting IATs onto tablets for ease of use in emergency departments and other clinical settings, and the field is going in this direction. As part of the fourth point I was making, we're now seeing tablets, laptops and tablets and handheld devices in waiting rooms, in primary care offices, in outpatient centers, in emergency departments where patients can fill out brief assessments. As part of that, we're putting implicit association tests onto these tablets. I think, you know, I see a future, I hope there's a future where you know, you go to the dentist, you go to the emergency department for care, you fill out a brief questionnaire for your dentist or for your primary care physician or your pediatrician. It'd be nice if we did the same thing in your psychologist's office or in the emergency department. And if we could include some very brief computer-based reaction time tests to measure things that you're thinking about or concerned about or ways that you're thinking that we can't tap with self-report. So we're going in that direction. We haven't brought in eye movement yet. One certainly could, and people may be, but the field is certainly moving in this direction.
Okay, thank you. I have a question regarding, it's another ICD question. Why do you think psychiatry, as opposed to other specialties of medicine, needs a separate diagnostic manual? Why don't they use ICD like other medical fields?
I don't know. I don't know. That's above my pay grade, above my expertise. One could take a cynical view and say because the American Psychiatric Association likes the money, you know, DSM-IV, 5 are consistently top sellers on Amazon and other book outlets, and so it is a big generator of money. One could argue that we're still working things out, and we don't yet have a system that's far along enough to sort of relinquish control over. I don't know, but I don't know. It's a really interesting question, and I don't know if there is an answer, and if there is, I don't know what it is.
Okay, I'm going to ask one last question. You've been so kind as to stick around. Explain the autism spectrum, controversy, and reasoning behind the change.
Yeah, so as I mentioned in the slide, in DSM-V, several different categories are now combined into one category. So autism, Asperger's syndrome, child disintegrative disorder, and PDD-NOS are now all just autism spectrum disorder. And the thinking is we're not able to make reliable distinctions between these different categories. There's disagreement on whether someone gets called or someone gets diagnosed with autism versus Asperger's, and there is not a great consensus on these different distinctions. So it makes sense to collapse these all into one condition. It's more reliable, it's more valid, is the thinking behind this. The controversy is, and there's disagreements based on which data from which study you're looking at, but one recent study said that if we use the new categorization system, about 10% of kids who meet DSM-IV criteria for one of these disorders no longer meet criteria for Axis 5. So what happens to these kids? They're getting services. They have IEPs in place at their school based on this disorder, and now we're saying they no longer have a disorder, they no longer have a problem. This is not acceptable, and a lot of families are up in arms, understandably, about this. And so there's a tension between what's been done and how that impacts the people in the world in a very real place, and what researchers think is the best classification system moving forward. And if people are interested, again, DSM-5.org has great information, really disorder by disorder, where there are changes. They have a paragraph or two or more on why this change was made, what the rationale was, exactly what the change is, and so on. So if people want to dig down, that information is up there and freely available and pretty readily accessible, and I'm sure described much more eloquently than I could do here.
Okay, well, thank you so much, Dr. Nock, for your presentation today, and thank you for everybody for attending. It was great having you, and thanks for all of your great questions.
Yeah, thank you, everyone.
All right, and I will be sending you the recording and the PowerPoint, and you also can write back to me to request the DSM-V guide. All right, well, thank you, and have a great day.